Morning, everyone. Welcome to House Healthcare. It's Wednesday, April 26th, and we are going back to our favorite, one of our We're going to hear, we heard from Department of Financial Regulation. We're going to hear from the pharmacists this morning, and then probably potentially table this until next year, but we'll see where the conversation today takes us. Before we do that, though, and I'm going to put you on the spot, Charles, right? Can you just introduce yourself? Because I don't think everyone has met you.
Yes, hi. So I'm Charles Becker. I'm a staff attorney with the Office of the Healthcare Advocate, and I'm here to focus on a few issues on the investment again.
Thank you. So we often have Mike in the room, but today we have Charles. So I just want to make sure he got to meet everyone. All right, so we're going to have Theo Kennedy for a couple minutes. So I'm going to have you introduce yourself, and then we'll move to Jeff.
Good morning, and thank you for having us here this morning. My name is Theo Kennedy. I'm an attorney in private practice, also a registered lobbyist. I call it a public policy attorney. I've been at the pharmacy work for quite a long time. I worked in government and just director of health rates and forms in what's now DFR for several years. And I worked as director of policy planning and regulation in what is now Department for Children and Families when Medicaid eligibility and covered services were together. I did that for about 7+ years. Been working for a decade on behalf of pharmacy issues in the private sector, and we really appreciate the opportunity to join the conversation a bit this morning. I also am glad that we have Charles from the Healthcare Advocate's Office. He's become, I think, what I would call kind of a PBM guru on the inside of the Healthcare Advocate. Very careful attorney, and similarly, Sebastian, I'm not going to cheat with his whiteboard, but it's a complicated area, and I think he did a tremendous job along with Ledge Counsel Jennifer Carby to kind of introduce what I'm going to talk briefly about today. So, and I'll try to be prompt. I'm just going to use this handout, which is also online, more as a reference sheet. There are a lot of links that you're familiar with, but to kind of put some structure. And then I'm going to pass it over to Jeff, who has got a lot more to substantive stuff to talk about. So I just wanted to put some context. Maybe it's the lawyer in me, kind of the way I think about things, there are many years of work in pharmacy in this building, of course. But in the 2021-2022 biennium, the last biennium, you all passed Act 131, which was H 353. And I want to acknowledge, because it was kind of a mistake not to do so, Representative Cordes Mari has really been so instrumental, along with your leadership and others, but in kind of listening to our cries and kind of trying to put some framework around what really can help preserve pharmacy in this state, and not just for independents, just the system as a whole. So anyway, you passed Act 131 last session, and I took the liberty to cut and paste the legislative summary, which is online there. I also given you the links to it. And I just highlighted a few areas because this law that we're going to look at more carefully, probably in the second half, if we're lucky, of this biennium, H 233, looks like it's the same bill, right? And that's partly because Jen Carby, in her wisdom, and I really support this, is trying to consolidate the pharmacy sections in the green books. And as such, it looks like it's all underlined, which would typically mean that it's all new, but it's not. Until you see that, I actually made a red line version for myself, but until you see the one that she produces, don't rely on me, you'll be able to see that some of the stuff in the bill as introduced now is already passed. So I took this opportunity just to highlight quickly one, and we can read for ourselves, I'll do it quickly. This quote at the top is actually also in your current bill, right? So this act expresses legislative intent to make prescription drugs more affordable and accessible by increasing state regulation of pharmacy benefit managers and to stabilize and safeguard against the loss of more independent and community pharmacies. And that second part of that paragraph is very important to my clients, of course, but not in a selfish way. I think it's, of course, often people are here to advocate for their interests, but I would say that as you hear Jeff and others that I've been working with, their intentions are a little bit more transcendent than that. It is, of course, that they can continue to thrive in our communities and be at the tip of the spear among the other clinical providers. But it's also that we're seeing things happen that will undermine the system as a whole. And we think there's some paths forward that can help consumers and Vermonters, small businesses and other parties in ways that just don't inure to my clients. So I just would quickly then, I listed the things that you already passed into law that in a sense, and out of deference to what you want to do, these things, once passed into law, are issues of adherence, compliance, and enforcement, right? So we're trying to support through data and communication with the Attorney General's office and other parts of the executive branch to kind of figure out what some of these new laws mean for pharmacy in our state and how can we pursue them outside of this building so that the things that you intended to have happen really happen. So some of those elements, and this is from the summary that already passed last year, and I'm not trying to be too selective, you can read the whole thing, but the highlights are that expands prohibitions on gag clauses, requires PBMs to allow pharmacies certain appeal rights, prohibits PBMs from reimbursing pharmacies and pharmacists in Vermont less than they would reimburse PBM affiliates for the same services, provides additional rights to pharmacies during a PBM audit, prohibits PBMs from requiring covered persons to use mail order pharmacies or PBM affiliates or from increasing out-of-pocket costs, that's all adjectival, right? When a covered person does not use mail order pharmacy or a PBM affiliate. And then prohibits PBMs from having network requirements that are more restrictive than or inconsistent with state or federal law, Board of Pharmacy rules. And let me pause there. Those are highlighted to say, and we could go into the weeds and you're not going to do so with me this morning, but you might have questions about each of those and you can go into the larger act to kind of see more about them. Again, as we view them, we're so thankful for all that. That was a heavy lift and you helped us succeed in putting these things into statute. And these are some of the curative measures we think that's going to help pharmacy if it unfolds the way this is contemplated. The last part of the bill that you passed last year requires DFR in consultation with interested stakeholders to consider issues including PBM licensure, spread pricing, pharmacist dispensing fees, and with the Board of Pharmacy issues regarding pharmacist scope of practice. And that's what gave birth to the great report that Emily and I'm sorry, I'm on first name basis, Deputy Commissioner Brown and Assistant General Counsel Arduengo talked to you about several weeks ago. So that's really going to give context. Holy mackerel, what a lot there, right? So why are we here asking for anything? You know, why would this bill be important then? Why don't we just pause there? Well, the kind of the biggest reason is that the bill is introduced, and this moves you to the second page. And I've tried to give the links. I also gave the link to the report. You already have the DFR report, but it's just kind of my context and timeline and kind of think about these issues. So in H233, the bill itself is really the National Association of Insurance Commissioners proposed model act for PBM licensure and regulation. And I'm, of course, not here to ever speak for any part of government, but I think if anything came out of the DFR report, if the resources are allocated to the department, they have an interest in or are not opposed to taking on the role that would allow for oversight of a licensed market place, because right now there's a mere registration required, and there are a lot of I'll just put it easily. There are a lot of, I think, rate making and whether rates are excessive or deficient that is kind of hidden from view to a certain degree unless some of this financial data is revealed. So getting to the end of my testimony, so I wrote VPA and VRD. So those are the two groups that I should have more clearly said I'm here today on behalf of. Vermont Pharmacists Association, which are a group of all the practicing pharmacists, and thank you for recognizing them last Friday. And then the Vermont Retail Druggists. So H233 has introduced, we support it in so much as it enacts a licensing and regulatory model for PBMs in Vermont based on the National Association of Insurance Commissioners Model Act. And again, I took the liberty of saying DFR has expressed support for this, provided staff resources are allocated to DFR to be able to do so. Last thing we would want is have some new duty that is unfunded and the staff and expertise to support Assistant General Counsel Arduengo not be in place. So that remains an open part of this. For us, really our only ask, kind of to be colloquial about it, if you go into H233, is around the minimum dispensing fee. And like most of DFR's report, we We thought it was excellent. It was very carefully researched. And if we do pay more attention to it, and I hope we are able to, you're able to rather, I'll call them off ramps. There are a number of off ramps, kind of, if this, they're not saying what should be done. Of course, they're not the legislature, but to lay out some of the alternatives and point to some best practices in other states, as well as in the federal government and the federal law, as to possible models for what we would want to do. In our view, for reasons that Jeff might touch on, but having a minimum dispensing fee is critical, right? I don't want to go into these weeds, but it's one of the few professions or few businesses, and I have some business background as well, that I've ever known where you buy something and then you don't actually control what you're paid for it, right? And so I think some of the, like the Mac Appeal stuff that you see in there, which I won't go back to, that's actually about just making pharmacists whole, just bringing them back up to what the actual acquisition cost was to them. It's not about them making an additional profit. So in that whole complex area of how are pharmacists remunerated, having at least some predictable benchmark is terribly important to the profession across its business profile. In the long run, we'd like to move away from the business side of the business and focus as pharmacists on clinical practice. And there's been a lot of work here in this committee that this testimony is not about on clinical scope of practice. And there have been some great advances where pharmacists have been able to join more fully, in my view, the team they were already on. But in any case, we want to make clear that we're not asking for this separate from a thorough review of ingredient costs, because you heard from Sebastian, if you'll recollect his presentation, that that's part of where the money is made by pharmacists. So we're not looking to hide any money. Quite the contrary, we support all the transparency that these laws allow for as far as financial data. So as I say here, VPA and VRD's ask, in quotes, is for a minimum dispensing fee. We're open to having that process include reimbursement for ingredient costs as well, so long as there's an objective and transparent methodology. That means for everybody, for pharmacy reimbursement and payment. While we encourage the elimination of spread pricing, if retained, we support full transparency at the specific prescription drug level, so policymakers can make decisions about the cost benefit of spread pricing based on all available financial data. And I think that's terribly important, because we would argue that spread pricing hides a lot of the financial data, and we're going to very carefully begin to reveal that to government in ways that I think can be useful. But that's really not our fight, right? That's not our, so we want to be careful not to be reaching, or maybe in Vermont metaphor, leaning too far over our skis, right? We basically want to stay in our lane, but help in every way we can. We really question whether the profit that is made in spread pricing benefits Vermonters, stays in Vermont, is not available for the rate reviewers in the submissions for rate filings, but that's something to explore more. But again, as the DFR excellent report pointed out, there are methodologies, and I believe I didn't bring it today, but I believe it's in the Medicare frame, where I was also lead counsel for Part D here in the state in our outpatient prescription drug benefit, so I have some familiarity with kind of that interplay between the federal and state, both Medicaid and Medicare, just for future reference in case I'm here before you. So yeah, so that's our view on spread pricing. We just want to get to the data, and we want to be able to share the data. The last area this morning that I wanted to touch on is in the bill itself again, which is what it's always about the bill, right? So at H233, starting on page 227, there's kind of a wholly different area. Everything up to that is this NAIC model in large part. There are some particulars in there that are not specifically the model, but starting on page 27, H233 also contemplates a state wholesale model. And I'll just read my thing and just say a few words, which will streamline drug acquisition, supply, and distribution, something we certainly found in COVID. And by the way, it's so great to be here in person. I'm sure we're far into it. You're used to it, but for me, reduce consumer costs and allow pharmacists to focus solely on the clinical practice of pharmacy and not the drug marketplace. A transition like that's not going to happen overnight. We realize this is a 3 to 10 year reality that we're facing, and none of our proposals, nor does this wholesale model upend the system in any way. It's trying to set up a new approach, perhaps akin to liquor control, where the state would sit in the driver's seat, and this would overlap your jurisdiction with government operations, I think, to some degree. But the bottom line is this other part of the bill, and we're really thankful for Mari including it. We had a version of this, and it's improved every year, over a decade ago, kind of as a freestanding thing. And in some logical frame, it is freestanding. So that's why I bring it up. And so I'd say to that end, the VPA and VRD respectfully ask, and maybe this is an ask that could be squeezed into this session. I don't know if there's language traveling that could be germane to, but that an off-session group of stakeholders be convened to research and report back on the cost, benefit, and possible design of such a model. And I point out here that initial research was done on a wholesale model when reimportation from Canada was being considered through S175, Act 133, and that was back in the 2017-2018 session. And again, reimportation, I know my time's running out, very complicated legal issue that likely made reimportation itself improbable. I want to be respectful to all those who aspired that it might work. But at the same time, the wholesale model itself was looked at very carefully. And again, it would be putting the state in the shoes of the purchaser and obviously therefore have also eyesight on what's known as switch data, which is the actual data in real time of every prescription that's being filled in the state all the time, which is already available. In closing, it's a little funny because I have 4 children and they're growing up in a AI environment, right? And AI is probably going to have its nefarious outreach pieces, and it's also going to have its incredibly useful and beneficial ones. We do need to rely on actual human knowledge, I think, and actual people in many ways. But we did, or I should say Jeff did, a quick, and I'll part with this, a quick AI, what would be the benefit of this wholesale model to the state? I think, or what are the benefits to a public pharmacy? And it doesn't necessarily need to be public, so it could, or state-run wholesale. And AI says, reduce costs, increased access, quality assurance, improved public health, and increased government control. Holy list, Batman. It really is like, okay, you don't believe us? Ask AI. No, yeah, reasonable minds can differ on many things, but I just wanted to close with that I think we agree with AI, that those are the things that would flow from a wholesale model. And in the link I gave you there's actual language from that year of a study group. So there could be a cut and pasteable language for a study group this summer. So that was my role, to frame this up in the context of ongoing work, recognizing all the things you've helped us with already. And then I'm going to hand it over to my friend, my client, Jeff Hochberg, who will show you the dumpster fire that is pharmacy. Things are pretty dire. We've lost many independent pharmacies, as you know. It doesn't just affect independent pharmacy. And if we were to, in the final words, I think if we had the foresight to design a system, we wouldn't design it like this. It makes up like 20% of the healthcare spend, at least 11% of recent rate filing propositions, or the increases are based on the pharmacy book, and parties aren't really in the fully transparent place to know whether the rate decisions are supported by the evidence. So we think there's work ahead, and that's all I had today. Any questions or concerns? Or
I think we'll hold questions to make sure
Very good.
Jeff has enough time.
Thank you for your time. Appreciate it.
Thank you. Appreciate that. And just, Jeff, come on up. And just to remind everyone, Jen, Carvey Legislative Council is working on a side-by-side of what's been passed in legislation and how this bill that is on the wall would do. So I'm not sure if we'll get to that this year. We'll cover it in June. Welcome, Jeff.
Welcome, class. For the record, Jeff Hochberg, president of Vermont Retail Druggists, partner and owner of the Smile City Pharmacy Group. We have 6 locations, Vermont family owned, operating here in Vermont since 1982. So I am here to follow up on Sebastian's seminar on PBM 101, which I could give extra credit to Sebastian. He did a great job framing this up for you all, and really want to kind of review some of that and go over that. And I wanted to pull up a PowerPoint presentation for you all that I created some visuals that I think would help solidify kind of an understanding as to how the system is working and not exactly working for us. I don't know how to do that. Join the Zoom. Did you send me a Zoom link? Sorry? 7:51, you sent me one today? Oh, I'm not connected to the internet. That would be why. So as I pull this up, before I get into kind of the overview of how this all works, briefly discuss if you sense any passion or urgency in my voice or my testimony, it's because the situation is real. CMS is aware of it. If you Google anything going on today with pharmacy, you'll see discussion of what's called DI Armageddon. There is basically a double-edged sword coming of it's reform coupled with a last-ditch effort to capitalize on the existing frameworks within the Medicare D space. And it's going to put massive constraints on the existing infrastructure of pharmacies today. So there's some slides in there that give you some high-level discussion about that and some of the discussion with CMS. There we go. Perfect. I did mute myself on my computer, yeah. Okay. So I'm joined. So now do I just share?
Yep.
Okay. Share screen. Wonderful.
There we go.
There we go. Okay. So who controls healthcare? Who should? That's the question. Nobody can really deny that the system isn't really working. There's a lot of issues, whether costs are rising, access is declining. Anybody tries to go get an appointment with a primary care physician, even that's problematic today. You're looking at 6 to 8 months for an appointment. Prescription drugs are challenging to get. And the supply chains disruptions from the global market have certainly added to that. And we're going to continue to see more of that in the coming future as we kind of work through these global markets. So 2 things that must happen in order for the state to effectively control prescription drugs. We must reduce the pharmacy benefit manager's control over the system through regulation and, more importantly, through enforcement of those regulations. Act 131 was a huge step for Vermont. It encompassed a large chunk of the necessary legislative framework to properly do that. Now we just need to give the tools to the right bodies to actually go after that. And then the other option is completely change the pharmacy model, which we do strongly suggest we consider. So in review of kind of what Sebastian talked to you all about before, he identified some of the monikers that are being used to describe what's the actual price of a prescription drug, right? So it's overly complicated. That's by design. Pharmacy is commerce. It's not technically healthcare. Statutorily, we're not healthcare providers. Healthcare facilities, absolutely, in my view. Is pharmacist a licensed professional? Absolutely. They are a key member of the community health team, and we need to support them in every way. But it's a business. And anytime you as a committee discuss pharmacy, please remind yourself that every stakeholder in the pharmacy chain is looking from a business angle and looking to make. That's why costs continue to go up. That's why it's not transparent. There's a reason for that. The spin is by design. It's meant to confuse you. And just when you get a handle on these acronyms for what pricing methodologies are out there, In 2026, CMS is going to try to change things. They're introducing new acronyms and trying to change the model entirely. So a lot's happening all at the same time. So stay tuned, but we'll go from there. I think one thing that Sebastian did an excellent job of going over with you all is that there's a huge disconnect between the finance of pharmacy and the actual product distribution channel, right? On the left side, you're going to have the actual product distribution. It goes from manufacturer to a wholesaler for distribution to the pharmacies to the patient. That's how your prescriptions come, right? On the finance side, we have this PBM model and insurance companies and premiums and all that. And if we went back to using those kind of the flow of money, how does that work? The patient pays the insurance company their premiums. A large chunk of your premium is based on the pharmaceutical expenditure, right? That insurer pays the PBM. The PBM reimburses the pharmacy reimburses the wholesaler reimburses the manufacturer pays the PBM. That's what rebates are. So that's the real cycle of flow that, this system created. And what we're seeing today, transitioning slides here, is that you have, in the early 90s, you saw PBMs joining forces with retail pharmacies or retail pharmacies purchasing PBMs. That was the CVS ProCare Caremark takeover 2005. You have Express Scripts for Cigna that now does its own mail order. You have Optum Rx, which is its own mail order. Today, there are 3 PBM companies that drive the lion's share of the entire pharmaceutical market. Okay, it is those 3. Something else you have to remember is that the principal customers for each major wholesaler are these national chain groups. Okay, so whenever something happens within the wholesale market, they always have that business consideration of, well, how's it going to impact my number 1 customer? You're not going to go to a Cardinal Healthcare or Amerisource and say, what's the change going to do? What's CVS are they going to pull out of this? Okay. You also have them combining forces. AmerisourceBergen and Walgreens. Walgreens Alliance Foods purchased 27% share of AmerisourceBergen, the number 2 wholesaler in the country. So they are completely, together. Cardinal Healthcare, the number 3 wholesaler in the country, pays CVS Caremark $200 million annually to participate in its GPO buying group. We'll get into those later on. It's called a company called Red Oak, just to use CVS's market share as the number 1 retailer in the country to better purchase drugs through McPharma. We're gonna circle back to that with something else that I posted later on here. So the wholesalers are tied and certainly dependent upon these PBM pharmacy companies.
Jeff, there's no PBM and wholesaler that are tied together though, right?
Yes.
There is.
Yes.
So PBM wholesaler and a CVS, say, okay.
So,
Like I said, so Cardinal Healthcare pays CVS Caremark.
And Cardinal Healthcare is what?
Wholesaler, I'm sorry. So
Okay.
Cardinal Healthcare is the number 3 wholesaler in the country.
Okay.
They pay to participate in a company called Red Oak, which is a group purchasing organization owned by CVS Caremark and Cardinal Healthcare jointly, to purchase drugs directly from pharma and manufacturers. So the PBMs have created these organizations, these GPOs, group purchasing organizations, to actually do the purchasing. That's where the rebate dollars and fees and all that stuff go, which also creates a whole problem for that actually passing down all the way down to the patient. Again, it's a roadblock. The manufacturers are entirely dependent upon the PBMs, the big 3 companies, for formulary placement. What drugs you take is entirely determined by your insurance company. You do not. I think you're going to be discussing prior authorizations here later on with Sebastian. Those formularies are all based on rebate dollars, are all based on a fee. If I can cycle to,
Does everyone remember what a formulary is?
I'm not totally sure.
Okay, can you
So-
just do it quick on the formulary?
so your insurance company, when you sign on to a plan, your insurance company gives a list of covered medications. Okay, these are the medications that will go through, if you walk into a pharmacy with a prescription, it'll go through no problem. They're the preferred agents.
And that is called a formulary.
That is a drug formulary list, correct? And you can
It's
go
just a list of the drugs that
that are covered.
are covered by your insurance.
Without
All right.
any extra documentation, without any prior authorization requests. It's where you're going to see brands covered over generics and all of that. So all of that is defined by your drug
Okay,
formulary.
yeah.
Act 131 put rules around what they can and can't do around those formularies, around changing product lines for consumer protection.
That's
So
where
that-
we see the tiers is when we hear people
The
talking.
tiers, all the tiers are set forth in your formulary.
So I'm gonna,
Yep.
to just also maybe link us back to yesterday's conversation on S65, right? We were talking about EpiPen, sorry, I don't know the full name. And, do we have, legislation that says one has to be offered at no cost share? That would, correct me if I'm wrong, those of you who know this answer for real, would go on a formulary list in a tier, right? And so tier one, potentially it would be covered with no cost share, but if you buy an EpiPen off of tier 3, it would not. So kind of bring it all together.
Okay.
Correct. We're talking about.
And tier 3 would probably be a brand rather than generic.
In most cases, your tier 3s are, so it's your, what's called a specialty drug tier. Now, Act 131 did codify that there's no such thing as a specialty drug unless the Department of the Board of Pharmacy deems it so. And that was a huge step forward because the massaging of the definitions is where legislation runs into its major hiccups with enforcement. I did put forward a transparency report that was put forth to CMS and presented to the FTC on the recent announcement of a 6B investigation into PBM activity. So from a manufacturer, Janssen Pharmaceuticals, partner with Johnson & Johnson, their transparency report listed, just talks about where rebates go, okay? And really what I wanted to emphasize in this is that if you read it, think about how this affects consumers and patients and small businesses and patients alike. So in there, they disclose that 54.8% of the list price of our medicines. Now, if we circle back to the list price is the price which the manufacturer sells to the wholesaler. Okay? So 54.8% of the list price is payments made to commercial insurers and other healthcare systems in the form of rebates and fees.
To explain that in something we can understand.
So manufacturers, part of that whole manufacturers being dependent upon pharmacy benefit management companies to put their drug on a formulary comes in the form of these formulary fees or admin fees or rebates, and they're defined in all different ways. But 54% of the price to which the wholesaler purchases the drug, the first point on that chain of actual product line and regular commerce, 54% of that price is that rebate. That, again, remember, is going to be inflated from the wholesaler to the pharmacy because the wholesaler has the cost of doing business and they're going to inflate the drug.
Excuse me.
Yeah.
Your voice keeps trailing off.
Yeah, you need to
Oh, sorry.
speak a little bit.
I usually get yelled at. I usually get yelled at for yelling, so I try not to.
You might want to yell. It's hard to hear.
Okay, so let me go back to this. So the manufacturer sells the drug to the wholesaler. That's the list price of the drug. Now the manufacturers are now saying that 54% of that price is the rebate and the fees for them to pay to the insurance company just to cover the medication for you, the consumer.
So if there's sorry, go ahead.
No, go ahead.
If there's something that costs $1, it's really $1.54 or whatever that percentage would be.
Right. So if a product costs $1, the manufacturer sells the drug for $1, it really costs them 50 cents. That's their price. The dollar that they're selling it to the wholesaler, half of that is going to the insurance company. Okay?
Why? Why is it going to the insurance company?
Because pharma is commerce. Pharma is selling a product. And in order for that product to be sold, they have to have it marketable. The only people.
Okay, so it's a marketing fee to be on the formulary.
Correct.
Oh, say it that way then.
Yeah.
It's a formulary fee, so.
Right.
Okay, yeah.
So now that price is inflated from the wholesaler to the pharmacy. That's what's called WAC, wholesaler acquisition cost. In truth, wholesaler acquisition, the actual price that the wholesalers pay is usually WAC minus.
Whack-a-mole, sorry.
Yeah, Whack-a-Mac-a-WB. So the invoice price that the wholesaler sells to the pharmacy is also inflated because of those rebate dollars, right? The pharmacy then dispensing into the patient, the retail price of the drug is also therefore inflated due to that formulary fee and all that. It all trickles down.
What are all of these inflated steps based on? Any clinical evidence, or who makes those decisions about how much it gets inflated along the way?
So, in terms of the inflationary steps on the commerce, on the actual product chain, you have a cost of doing business, right? So the wholesaler purchasing the drugs from the manufacturer has to recoup its expenses and make a profit to continue doing business and distribute the drugs. So there's a cost of doing business where we would expect. Pharmacies naturally should be doing the same thing. Arguably, we don't have any control over that, so there's really nothing there. But those are the inflationary steps. Now, it all starts from the manufacturer and their price of the drug, and which is dependent, 50% of which is dependent on their ability to negotiate with the insurance companies to place that product on your formulary.
Art, and then Alyssa.
I'm trying to understand the sense behind the formula. I know. It seems to me that any drug that's not illegal would be available to anybody at any time for a physician to, if I go to a doctor and there's a certain drug that has to be ordered, the insurance company, would cover it. It doesn't seem that it should be a restriction by the formulary. Therefore, the fee is unnecessary.
Wouldn't that be fabulous?
Art, I think you just nailed it.
That's the question.
Okay.
That's $100 million question.
You said it, why? Really, why is it?
Okay, so the formulary really is the problem?
No.
It's tricky. There's 12 versions of a beta blocker.
Right.
Yeah, right. So could you explain that?
So there are 12 versions of a beta blocker. There's brands, there's generics, there's therapeutic equivalents, there's all kinds of different drugs, different manufacturers. Those manufacturers sell to wholesalers at different rates for preferred status, because guess what? There are preferred status within the wholesaler market, and trickles down to the retail market. More rebates, more of that, all of that allowed by the 1993, which again continue to inflate the price and hide the actual acquisition cost of the medication. That's the question. Get pharma in this chair and say, how much does it cost for you to produce and sell epinephrine without consideration of the insurance company? Ask that question.
Art, was that helpful?
Yeah.
I know it's not.
Yeah, right. No, that's fine.
Alyssa.
You keep saying insurance company,
Right.
but are we really talking about the PBMs? Because Who sets the formula?
Well,
The
that's,
insurer or the PBM?
Yeah.
Half of the insurer.
that's an interesting question, and I'm glad you raised that. So as we move down, we saw how the pharmacy, the PBM is tied to the manufacturer. What about the insurers? How dependent are the insurance companies on the pharmacy benefit managers? Have you ever seen a contract between an insurance company and a pharmacy benefit manager? I would encourage you to look at those. Act 131 did something great about us being able to disclose information under confidentiality. So the game of this is proprietary information that we cannot share, no more excuses. Disclose it. Show it. Show us what you're actually paying. I would say that if you were to see those, you would be shocked.
But the insurer is actually paying for the drug.
What the insurer is paying for the drug, but also how dependent the insurance company is upon the PBM.
Well, the PBM helps them get the best prices, right?
Do they?
That's the intent, but they may not.
Exactly. There's no comparison. The PBM keeps the contract that I, as a pharmacy owner, have with the PBM completely separate from this contract with the insurance company. No two, they shall never meet. The insurance company, Blue Cross Blue Shield and MVP do not know what my contract is with their respective PBM entities. How many people at Blue Cross Blue Shield or at MVP actually work in the pharmacy departments? How invested are they? How knowledgeable are they on these things? These are the questions that you ought to be asking. I would say that they are extremely dependent upon pharmacy benefit managers. I'm going to go a step further. The insurance companies, the largest insurance companies in the country, United Health Group, Aetna, Cigna, guess what? They own PBMs. Therefore, they own mail order pharmacies. Therefore, they have the influence directly with the manufacturers. They have as to what drugs to cover. And they are then therefore the number one purchasers to the wholesalers. Who's in control?
Maureen?
Trying to restate this as I understand it and tell me if I'm correct. If we're looking at the bigger picture where there are horizontally and vertically integrated companies that are the wholesaler, the insurer, and the PBM. The PBM controls the formulary, what's on the formulary. And it's often driven, what drugs go on the formulary are often driven by a financial relationship and incentive with the drug manufacturers. And there are rebates and other goodies behind the scenes that were proprietary, so no one knew if those rebates, discounts made it all the way to the person buying the drugs. It seems that most of it was trapped behind in the black box, as we called it. So, and we had no idea how much that was. It also, in the designation of specialty, meant that PBMs could force people into buying a medication that their provider didn't prescribe because it wasn't on their formulary, could force people into mail order and also purchasing 3 months worth of a medication because that's how they do business, even if you don't need 3 months of that medication. And in addition, the insurance companies for whom the PBMs are supposed to work for didn't have detailed drug by drug itemized information about, they only had aggregate data about how much the PBMs were paying the pharmacies.
Correct.
Did I get that right?
Yes.
Okay.
Helen?
So maybe this doesn't pertain to this, but there's no antitrust anything that's like layered on
Ah, yes, so.
top. So I just seems very like, wow.
Boom, right? I am not a lawyer,
Either am I.
but I will say this. There is a very good reason the FTC is now launching what's called a 6B study, which can take 5 to 6 years, as they project, to investigate the relevance of an antitrust litigation against PPM industry. The OIG has launched an investigation.
Who's OIG?
The Office of Inspector General for HHS, Health and Human Services, they have launched their own investigation into PPM activity. The House Oversight Committee, where our Representative Ballant will be serving on these health subcommittee, will be calling in the big three PBMs to testify as to the comings and goings of their relationships in this business construct that we call pharmaceutical distribution. There's a lot being discussed. There's a lot of questions being raised. I think as a general layperson's understanding of the law, this screams to me about some serious issues. I will tell you that Vermont is one of the few states that's being looked at from a national level because we have a very consolidated market. We have 2 active participants on the exchange plans. We have a small population base. It's easy for them to get data, and they are actually fully aware of the great work you all did with passing Act 131 and the ability for all stakeholders to disclose information under confidentiality to regulated bodies.
Art?
Yeah, could you go back to your slide with the buckets, the multicolored circles?
Should I pull it up? Yeah. I was going to talk about real quickly about the whole formulary thing real quickly, and I'll come back to that.
Yeah, just for a second, any one of those. If I wanted to start, say I wanted to say Peterson Drug Wholesaling, okay, start my own wholesaling business. Could I not bypass the system and sell directly to a customer who would go to their physician, get a prescription, and come to me as a pharmacy or a pharmacy that I would support and maybe sell the drug at the cost it would have to be?
Short answer, yes. Long answer, Mark Cuban stole my idea.
Oh, right.
Mark Cuban, 2 years ago, launched Drug Cost Drugs. Cost him $1 million to start it up. Started a wholesaler. Started purchasing drugs from a manufacturer, starting with generic drugs and going from there, building out, selling drugs at a true acquisition cost directly from the manufacturers to through his mail order pharmacy that he purchased for $1 million, and started distributing. I think the stock has doubled since that time. I've heard that Blue Cross of Pennsylvania is even joining it. You think it's a wild idea? It's been done. It's not new. We actually did something like this back in the early 2000s when high deductible plans first came out. My company reached out to one of the association groups who had all these high deductible plans and said, hey, what can you do? Said, we're going to sell the drugs directly. We're going to bypass the PBM. This was all through Blue Cross Blue Shield at the time, bypass their PBM restat at the time, and file claims directly with Blue Cross for cost plus. We did cost plus $9. Everybody on that association plan had huge savings and passed all those savings on directly to their employees for that plan. But it was kibosh because it was bypassing the whole infrastructure of the PPM model at the time.
So,
What do you mean kibosh? Well, wait a minute. What do you mean
It was ended.
kibosh?
We were told that Restat no longer would allow this to happen. It was too problematic, and it ended. Blue Cross.
and so in the Mark Cuban example where he's created this company, which I heard about, why aren't others doing that?
Don't have the money, maybe.
I would argue you don't need a lot of money. There are pharmacies now today that are now doing cash only. I would say that this committee is going to become very aware of the level of participation amongst pharmacies in this state within the insurance market. We, as my company, I speak for my company alone, but my company, we are considering no longer participating in some of these plans.
Say that again.
Yeah, you're trailing off.
So my company is considering no longer participating in some of the insurance plans offered under the exchange.
And
Because-
so as a consumer, and I know that Bobby, I know you have a question. So as a patient, I go to my doctor, I have a prescription for something. I come to your pharmacy, it would be a cash only.
Right. And I would save you money. That's how bad the system has gotten. That is why the stink of this has reached the FTC. And it was unanimously decided among both the Republicans and the Democratic members. It stinks. It's gotten that bad.
Bobby?
Oh, a couple questions. The one about the 54.8% cost, that is an average of all drugs, or is that specific, are some drugs higher or some drugs lower, depending on, like if there was only one version of a drug available, why would they need to market it if there's no choice? Do you know what I mean?
Yep. So that's exactly right. So when the blockbuster drug for Hep C came out, company Gilead, right? When they produced that drug, there were no rebates, none.
Okay.
And that was because they had no competition.
There were no rebates, but the drug was still extremely expensive.
Yes, because there is in fact a level of R&D and costs associated with producing these drugs, which have sustained humanity and come a long way. So we do have to respect that.
Yeah.
But we can't even begin to go after the manufacturers for what their pricing is until we understand all this nebulous black box that's happening in the middle. That's the problem. We can't even attack those questions because they have a defense. And they're right.
Bobby, I think you have more questions.
Yeah, just to follow up on that. So the Mark Cuban cost plus model, they don't do that 54% thing because they're not trying to influence the formularies. So
Correct.
they're basically like an open menu of a la carte,
Correct.
anything you want, right?
Right.
And that's where the money savings come from.
Correct.
Okay, just making sure.
The money savings is coming from there. Even at that, it's still not as great as it could be. It could be better. And remember, most of the business is generic drugs. So those rebate dollars are much less. You're talking pennies in terms of the percentage.
So I have Alyssa and then Mari, and then we only have till 10:15, so I want to make sure, Jeff, if there's key points, that he has time to do that.
Well, I just wanted to, because you mentioned that you're thinking about moving in a different business model direction. Currently, right now, are you allowed to, I'm assuming you have contracts with the insurers, which may or may not allow you to do this, but can you just offer to the patient, hey, here's how much your insurance is gonna charge you for this, but I can sell it to you without going through your insurance for cheaper. Can you do that now?
Yes.
You can't do that now.
Just remember though, my contract is not with the insurer.
Yeah,
My contract is with the PBM. I do not contract with Blue Cross I do not contract with MVP directly.
and there's nothing in your contract with your PBM that says that you can't bypass them.
There's nothing we have the protections under legislature that I'm allowed to disclose to them the cash price, and I'm allowed to offer them a different cash price if one's available. If I bill your insurance company, my contract dictates to me that I must impose the copayment that they determine. So no matter what it is, which we'll get into, that raises some other legal questions as to what's going on in there. I wanted to quickly talk about the formulary stuff and the brand versus generics. And we talked about this briefly too, about Suboxone. And it came up, but there's multiple drugs under this list, okay? Suboxone was just the one example that was being discussed here in this committee and why I brought it up. And I wanted to highlight to you, this is my cost. $260 is the cost for 30 Suboxone film strips, okay? The generic cost me $60 for the same 30 count. A drug Lialda, which is for Crohn's, costs $1,000. The generic cost me $152. Even if we use that 54% rebate, and we suppose that the insurers are doing their job and actually getting 100% of that rebate and passing it on to the insurance company. That's still not making up the difference in some of these cases. The insurance companies and their abilities to determine formularies in time with real market knowledge and real costs is not there. The drug Latuda recently went generic 2 months ago.
For depression, right?
Right. Yeah.
You should let people.
It's a antipsychotic and depression medication. Cost
So just think about that population, 1,000 versus 6.
30.
It's huge.
1,000 versus $6, but it's still the preferred agent under Vermont Medicaid formulary. Symbicort, still preferred over its generic. Vibrant, another one that just went generic, $300 versus $23. They don't make changes fast enough. They don't have the knowledge of what the actual costs are of these generics to make determinations because they are dependent upon the PBM to manage their formularies for them. They don't know. They don't know what I'm paid.
Maureen has a question and then we're going to let you go.
It was just a comment back on the R&D thing, the cost of research and development. I want to point out that taxpayers fund a huge portion of research and development for pharmaceuticals, and potentially every medication in the last few years has been funded by the NIH, by our tax dollars. So they're not taking this.
Federal dollars, Mary?
Your tax dollars.
Well, fed, not state.
Federal, yep. So just remember that when the drug companies complain about research and development, it's real, but the federal government funds a lot of it.
Leslie, do you have a quick question?
I have a question for you, which I would just want to get in before we end.
Okay.
So this is the current state of healthcare. The PBM and the insurance, this PBM, insurance company, pharmacy, wholesaler, oligarchs control oligopolies. I'd say they're monopolies, but I'm not a lawyer, and I would certainly challenge that. But these single entities, 3 of them, control the destiny of healthcare in this country. Because let's really boil it down. How often do you see your doctor? Once a year. If you're the average citizen of Vermont goes to see their primary care doctor once, maybe twice a year. They discuss plans, regimens for their therapy. They say, okay, let's do a prescription drug. We're going to try this for 6 months. I'll see you back in 6 months. Prescription drugs is the capital driving force for all of healthcare. The CMS publication from the National Association of Community Pharmacies published out a real breakdown of where costs are. That's not the claim. Here you go. Really broke down the pharmacy costs. Okay, you all have probably seen, I imagine you've seen discussions and the rate reviews, and Mr. Becker here can probably attest to that the rate filings, the dollars associated with your premium costs, the rates associated with that, are dependent upon what are we paying for, right? We're paying for a service from our professional doctors, and all the other healthcare entities in there. And I'm not going to discredit them in any way. They certainly do a lot for us, and we need to encourage their participation. But from a business model, remember, pharmacy sits over here in this business world. We operate where our gross profit, our revenue versus the cost of acquisition of those drugs is on average 78%. So I'm working with that 22% margin to run my HR, my expenses, and that's being continually peeled back, and this goes into some of the detail on that. But on the other side of the coin, on the medical side, it's the opposite. It's roughly 60, 70% of the revenue goes to HR. So this is, I bring this up not to discredit anybody, I bring it up to drive a point home. Pharmacy is the line in the sand where commerce meets healthcare. Okay? We've been bouncing back between these 2 realms for decades. And it's where I suggest this state insert itself in some capacity to peel back the onion, to start putting pressure back on those rates, understanding the costs that underpin those rate settings, to better save Vermonters money, to better save the small businesses who have to help cut labor costs. That's what's going to help healthcare. We need to better understand, have a true understanding of where everything is driving. I don't want to eat up too much time, but Theo did mention the pandemic showed us something fantastic that I couldn't have asked for. The drug Paxlovid that came out under emergency authorization for the treatment of COVID, how was it handled? Wasn't done, the manufacturers didn't go to the PBMs to make sure they put it on every formulary. It went right to the Department of Health. It went right to the CDC, to the Department of Health. The state of Vermont got all those medications in. Lucy Lieberman, over there at the Department of Health, I would call her and say, hey, I need to place an order. They have a whole tool now. I placed an order online. I got product in at no cost. I dispensed it out that day. I got paid a reasonable dispensing fee, even from these same insurance companies that want to argue that spread pricing and these 20-cent dispensing fees are adequate. They would actually pay me $10 because that's more appropriate. So, and it worked. So we have the capacity to do that. We have the tracking capability, the VPMS system for tracking controlled substances, right? Takes in, every pharmacy has to report daily to the VPMS system. And they filter and generate, they are lagging. Every report is different. And they struggle. They actually just changed vendors recently. And it's still having some lag issues. But what's fascinating is that you could go out there and you can actually request all this data. Or in between my pharmacy and the PBM that actually adjudicates the claim. Pharmacy has been doing this electronic claim processing since the late 80s, before AOL and Messenger and all that. I remember those days. And there are companies called switch companies that put the data, all your pharmacy claims data into one format, the NCPDP format. I think we're on version 11 point something, and send it off to the PBM. The PBM comes back to the switch, back to the pharmacy. Real time, real data. Now that data set is available for purchase. Guess what? Your insurance companies sell that data to process what IHM, now IQVIA, is the largest data aggregator that sells it back to manufacturers for more marketing research and analysis. Your data is sold 7 times over. If you've gone to ask for life insurance or anything like that, guess what? They pull up your information. They see every prescription drug that you've ever dispensed. They see every prescription drug that even wasn't dispensed that was just put on file. And you maybe never got because it needed a prior authorization. And then they create diagnoses and risk evaluations. So everything is driven from the data. Data is power. We need to control that. We need to better get that data, and it is available. That's what companies like Drug Cost Drugs is actually doing. That's what companies like Amazon, when they announced their JP Morgan, Berkshire Hathaway self-insured model where they're going to do everything in-house, because they can save money and they can control the data. They can cut real costs and real action, and you can do it for the greater good of Vermont. That's what we propose.
So I know we have Art and Leslie.
I have 100 questions after all that you said, but I'll stick with this. What is the physical difference between a brand name drug and a generic drug? Why is that discrepancy in price? What makes that? Is it different products in the actual drug?
In some cases, yes. But the active ingredient the active ingredient is the same. The chemical structure, the
In the same percentage.
in the same percentage. Well, no, not necessarily the same percentage, but in the same dosage form to you, but in the same percentage of the tablet. What makes a tablet a tablet? What makes it pink versus blue versus yellow? What is in the gel capsules? All of those things are the excipients, the inert ingredients. Now, you really want to get into the weeds, you start learning about the global supply chain and how the pandemic has disrupted that, which is one of the causes for these massive shortfalls in product availability in this country. This country creates a contingency plan for active ingredients. Manufacturers keep on hand about 3 years worth of active ingredients, but they only keep about 3 months worth of the inert ingredients to actually manufacture the tablet.
What was that you said?
They keep 3 months of the inert ingredients that make it pink or blue or whatever have you on hand. Most of that, guess where it comes from? China and India.
I was gonna say China.
China and India, the number one producers of both the active ingredients and the inert ingredients. We don't have the capacity in this country to do that.
All right, did you have more?
Well, but it doesn't sound like, is it the process of making the drug that makes it more expensive?
So the idea behind brand versus generic came over from patent. So they did this R&D, they invested in this studies, they created a chemical compound that's going to help save lives or help treat an ailment. They deserve some compensation for that, right? Rightfully so.
Okay.
But when that patent expires and it goes onto a generic market, that's when the price falls.
Okay, so it's the patent is the driver for the change.
And now there are all kinds of litigations about patent protections and all that stuff too. So we're not going there.
That's all I need, yeah.
Leslie?
So I'm thinking about all this and it's big and it's a morass. And we have H233 on the wall, thanks to Maury and all those that worked on it. And I'm wondering, Theo brought up the idea of a study for the summer. And I'm wondering what we need to do to tee up H233 to do it for next year. And what does that require? And I'd like to see how we can do that. So that's my question for you and us. So that we can be prepared in January to really do this work that is clearly needed.
I would suggest this committee that the committee, and maybe in part with GovOps, I'm not sure because there is some interplay with how that would work out, but with whatever committee members you see fit, form a task force and utilize Act 131 in obtaining real data. Last time we worked on this, which was pre-pandemic, I remember we formed a task force with the Green Mountain Care Board. I was on that task force. And at the first meeting, I sat there, and everyone's like, what's the ideas? What can we do? And my suggestion was, let's pick a drug. Everybody put their cards on the table. Nobody wanted to play ball. That's what needs to happen. You want to begin the conversations. You want to start being able to ask the right questions to the people that sit in this chair, start getting some real data in front of you. And you have the power and the authority under Act 131 to do so.
So may
I don't have an answer for you right now.
No, I know. Well, my question, and that's the question, is what does it take to stand up task force? I don't know that. And that's what I'm
It
curious.
takes legislation and it takes money, and we're in the 11th hour of a budget. So we have some limitations, but that's not to say we can't form a committee group who wants to work over the summer. But an official in legislation pays per diem, that's, we're too far along in the process, I think.
Totally get that, but whatever it would take to start a task force, I would really like to see happen.
I don't know if I would call it a committee. It would just
Committee, sorry, okay, whatever is
like
the
a
right,
project over the summer.
I don't
So
care,
let's
it's
talk
not
about
the right
that.
term.
What you would need is some kind of government entity, organization, committee, what have task force that is able to keep information, that is designated to keep information confidential, because you are talking proprietary language. This does rub up against contract law and proprietariness. So you do have to be careful. I would encourage certainly involvement in the Department of Financial Regulation, the Attorney General's office has some
And that's where
it gets.
it gets a little bit too much for the time we have available in front of us.
Madam Chair, on Farm Association, Vermont Retail Druggist, a couple things. One thing is the new law, Act 31, actually opens doors to data that we didn't have before. And I think that in conversations with the Attorney General's office and others, we want to carefully kind of titrate that data, but really an off-session task force that could look at some of this we haven't seen before and kind of get the lay of the land a little more clearly financially. And just quickly, I want to just two other things I heard when we came here talking about financial stuff, right? The formulary, just on 2 points, formularies also have clinical underpinning, right? So they're pharmacy and therapeutic committees, they're drug utilization review boards, depending on which payor you're talking about. So there's a validity to around clinical safety and efficacy, not just originally from FDA, but up through that process. We're not here to condemn a valid formulary process that recognizes clinical underpinning. What we're saying, if you look behind it, the financial incentives, you begin to understand why in a state where we have a generic substitution law, why sometimes you find when a patent is over and there's a generic substitute available, that it's nonetheless so that a brand name remains preferred and that those rebate dollars don't necessarily travel to us. So, and the other thing I want to just make sure that we're not, again, we work with our partners. It's very, Blue Cross Blue Shield Vermont has a contract with PBM, they're agents of the insurer, right? So we think the model that Medicaid adopted with a much more pass-through approach, which uses the pharmacy benefit administrator function, where they need that kind of support and help around claims processing, around auditing, but not in the drug purchase part, right? That's what we're trying to say doesn't work. And we don't think it works for Vermonters as far as premiums at the end of the day. So thank you for letting me jump in on that.
Yeah, I think one final point is that, you know, in your time that you have, certainly I'm here to answer any questions the committee may have in off session or any point in time. I'm happy to help. But I would encourage you all to just do quick Google searches. You'll see things like states like Oklahoma, where the insurance commissioner of Oklahoma, Mulready, is actively litigating against these PBM entities for steering, consumer fraud, and all kinds of different things. So the state of New York passed a bill a month ago around changing their Medicaid system from a managed care, which looks more like your commercial insurance today on the exchange, to what we have in Vermont Medicaid, a fee-for-service, open book model. The reason they did that is because they sued the PBMs for $300 million of overcharges the year before. Okay? This is happening across the country. There is a storm of PBM reform and litigations, Ohio, North Dakota, Oklahoma, Arkansas, the list goes on and on and on. There's constant litigations going on about overcharges, particularly to the government. The state auditor has raised questions about your own insurance plan and what was charged in those. Every time the state of Vermont has ever looked at its insurance plan and it's found overcharges. There's problems and it's a mess. And it's so late in the game that unfortunately we are going to see a massive failure of the system because we have this global market recession happening, workforce issues, coupled with massive federal reform, and it's all happening at the same time. There's a lot of pressure on the system today. And
on that happy note. Stop you right there. Brian has a question.
I think I'll jump out the window.
Everyone hold on please, because I want to get a break in and we are back here at 10:30. Brian has a question. We're going to take a break and we'll have a committee discussion.
Yeah, it's a question, comment, and to come back to it, but like, I've been listening the whole time on Zoom and I don't think you can see on there. And I feel like this is actually like emergency level issue. Like, and I saw us shut the entire state down in 2 days. I converted my entire practice to telehealth in 1 week when I had to. And I don't see why we couldn't amend maybe S65. I was looking at the underlying law right now and create the task force. I just feel like we shouldn't wait, that's all. So we can come back to it, but I just feel like if maybe we put our heads together outside a committee and come back when there's gonna be little pockets of time when we're waiting around over the next 2 weeks. And if we can't do it with S65, ISC bills can be completely turned into something different. I mean, like the feminine hygiene products bill turning into miscellaneous tax bill, for example. So there might, if this bill can't be the vehicle, the second option would be why not in the state budget? Like there's task forces embedded in the state budget. This is related to the appropriations of the state. So just putting it out there that I think there's pathways that we could explore. Thank you. I just wanted to say that before you left.
Thank you, Jeff. We're going to take a break until 10:30. Please be back here at 10:30 because we have another very important topic.